This is Connor Meadows going over the supraventricular tachycardia algorithm for paramedic protocol. If you have a patient that you have found and you have already determined his airway, breathing, and circulation, and you have got him hooked up to a monitor, and you have done a 12 lead or a 4 lead and recognized it to be supraventricular tachycardia, the algorithm goes as follows. Supraventricular tachycardia presents as a beat of 150 beats per minute or more. You are going to be considering the H's and T's for the duration of the period that you are dealing with the patient. So you are going to maintain the patient's airway, assisting the patient's breathing as necessary, giving the patient oxygen if he's hypoxic, and you will be determining what the patient's blood pressure and pulse oximetry is for the duration of your time with the patient. If the patient is symptomatic and unstable, meaning he has hypotension, altered mental status, signs of shock, chest pain, the patient is systematic and he needs to be synchronized cardioverted immediately. If possible, you want to consider sedation, but you don't want to do anything that will delay treatment. If it's regular, narrow, complex, you want to consider adenosine. For adenosine, the IV dose is 6 milligrams rapid IV push, followed with a normal saline flush. Second dose of adenosine is 12 milligrams if required. If the patient is not symptomatic while they're in SVT, you will simply transport the patient and consider consults with the doctor and medbase. If the patient's QRS is less than 0.12, then the patient will not be given cardioversion. Again, the biggest determining factor is if the patient is symptomatic or not. Symptomatic patients with SVT get electrotherapy. They get synchronized cardioverted. If they're not, you will be giving them medications if necessary, or you will just be transporting the patient. You are giving adenosine to slow the rhythm down, hopefully enough to identify what the underlying rhythm is. So, in summary, to go back over the treatment, you want to always attempt to identify the cause and never delay the treatment. Other treatments for SVT can be vagal maneuvers, as well, obviously, as synchronized cardioversion and medications. You want to make sure the patient's oxygen is saturating at least 94%, and if the patient is unstable, then they will be getting synchronized cardioversion. Rules for cardioversion are QRS that's narrow and regular. You're going to cardiovert at 50 to 100 joules. QRS narrow and irregular will be cardioverted at 120 to 200 joules. QRS that's wide and regular will be converted at 100 joules. And QRS that's wide and irregular gets defibrillated, does not get synchronized cardioverted. Other medications, again, that you can consider if adenosine is not effective is procanamide and amiodarone. You can also consider, if they convert with those, to consider an antiarrhythmic drip or infusion. And again, you always want to be considering the H's and T's throughout your time with the patient.